Heart failure is a condition. It's a state. You know, it's never a primary diagnosis, meaning it's never the single diagnosis. There are many causes of heart failure. We'll examine a few today. Just like being broke. So if you're broke, is that a primary condition? No. How did you get broke? Okay, maybe you're jobless, or maybe you have one or more jobs, but you spend way too much. Okay, you got 4, 5, 6 cars. Okay, it's way too much. Okay, unnecessary expenses. So just like heart failure, of course, this is a not just a that's not your only problem. You have to treat whatever led to that condition. Okay. So what is heart failure? It's a state wherein your heart is so damaged that it's unable to do its job. The heart has one job, which is to pump blood. It receives blood and then it will pump it out. There are 4 chambers, so 4 pumping chambers. There are 3 types of heart failure. We have left, right, and then we also have normal cardiac output heart failure, but we'll only focus on the 2 most common, which are right and left-sided heart failure. Left-sided heart failure, the old term for that was congestive heart failure. Because of the nature of it is there's congestion, but there's also congestion in the right side as well. So they did away with that. We just call it left side or right side. So for risk factors, let's say you get question on the NCLEX, who are at risk for heart failure. Here are your answers. Okay, so ethnicity, African Americans and Hispanics. For age, then of course it's over 60 years of age. Other risk factors are, does that include also SIADH? SIADH? Yes. What about chronic kidney disease patients? Yes. Okay, so people on dialysis, yes, those patients are also at risk for heart failure. Like I said, there are underlying conditions that led to this condition. So risk factors or underlying conditions are, this is just one, atherosclerosis. We'll discuss this again next semester when we get to coronary artery disorders. So heart attack can cause heart failure. Or let's say you have, it doesn't have to be cardiac all the time. It can be pulmonary. Say you have COPD, for instance. COPD causes pulmonary hypertension, meaning it strains the right side because the right side pumps blood to the pulmonary arteries, right? So if you have COPD or any other chronic disease, cystic fibrosis, for instance, or lung cancer, that increases pressure in the pulmonary circulation, particularly in the pulmonary arteries, that can cause heart failure as well. Okay, so this is what I mean by there's so many causes, okay, that can lead to this state, this condition. And once you have heart failure, it's permanent. It's now a chronic condition. So as with any other chronic condition, do you have to stay in the hospital? No. Diabetics, COPD patients live at home too, right? Cystic fibrosis patients live at home. So therefore, it's a chronic condition, which as long as you take your regular medications to help maintain cardiac output, we'll get to the medications later. You'll be, living a relatively normal life. However, there will be exacerbations. There will be flare-ups because, of course, you're alive, you live life. So, of course, you're not going to cheat every now and then. Okay. Here's another cause, cardiomyopathy. So this one is a abnormal shape of one or more of your heart chambers, or sometimes depends on the type because there's many types of cardiomyopathy. We've got dilated or constrictive cardiomyopathy. Okay, some of these are you're born with, meaning you just have a bad heart at birth, or some of them develop over, let's say, especially malnourished patients. Let's say those with anorexia, for instance, or alcoholics, or even pregnant women can develop cardiomyopathy as well. Here, alcoholics, alcoholics, they can, any, even cancer patients, okay? If they suffer malnutrition for a long time, that can cause heart failure as well, because they damage the valve, and valve disorders cause heart failure. Okay. We'll discuss valve disorders separately. That's later in the semester. So I mentioned kidney failure. So both acute and chronic heart failure can lead to, acute and chronic kidney failure can cause heart failure. Because what's the number one job of the kidneys? And so what's that filtrate? Urine, right? So it's supposed to make urine, get rid of urine. So if it's not doing that, what's happening to the water that's supposed to come out as urine? It's staying in the circulation, causing increased workload, right? So leading to heart failure. Dysrhythmias can lead to heart failure, such as AFib or VTAC, for instance. Okay, so some serious, not only valve disorders, but dysrhythmias, as long as they're sustained, they can cause heart failure, acute and chronic. Or even electrolyte problems. They can lead to, because electrolyte abnormalities lead to dysrhythmias, and therefore dysrhythmias can also lead to heart failure. So how is this tested? Select all and apply. Right? So you pick which ones, or maybe drag and drop. Okay. The pathophysiology is really similar to what we did already last week. Remember the RAS discussion and sympathetic system discussion we did last week? Here. You remember this? Because once you're in heart failure, that means the pump, is it effectively pumping? No. So cardiac output will decrease. So that means, is there low blood pressure? Is there low oxygen? The other triggers may not be present, but remember, we only need one. So once either blood pressure drops, which means oxygen level will drop because blood carries oxygen, right? It will automatically trigger RAS as well as sympathetic nervous system. Now, the patient's heart is already in failure. What's the effect of these automatic responses on the failing heart? Is it going to help? No, this will be your demise. So the patient will die because of our compensatory mechanisms. Okay, this will actually, instead of helping the patient, this will kill the patient. Okay, because we can't help it. It will automatically be triggered because once the heart fails, let's say you're in acute heart failure, blood pressure drops below systolic below 90. So it will automatically trigger RAS. So therefore, the patient's heart is already in failure. Now it's forced to work even harder, pump faster, pump harder against vasoconstricted arteries. Okay, so that's why the treatment will be what? What's the main treatment for heart failure during an acute episode? Suppress these two, right? Because this will kill the patient, right? So therefore, if you notice our drugs, what are they? So let's go to the drugs now. There's not much we can do for cardiac. Only medications will work. Okay, you can't talk your way out of this. You can't say, hey, let's sit down and talk about your shortness of breath. How do you feel? Okay, can you do that? No, the patient's dead. So all we do here is give medication after medication. Right. So here, you can read that on your own. I won't repeat it. So this is now the automatic trigger. Okay, all caused by our compensatory mechanisms. Okay, because of the RAS, it's built in, it's automatically going to be triggered and it will kill the patient. So we have to suppress those if we expect the patient to survive. Okay. You still remember BNP, right? What was BNP again? Which will do what? Effects will be opposite aldosterone. Okay, opposite aldosterone. Aldosterone causes water and sodium retention, and the renin part will cause vasoconstriction. So BNP will do the opposite, which is and diuresis. Very good. Okay. But so therefore, does this mean that just leave the patient alone? Because BNP will take care of it. Unfortunately, no. This one, it will help, but obviously it's not going to be enough. We have to help the patient. So the patient's short of breath, that's the main complaint. Can't breathe. You go to the ER, we give them vasodilators and diuretics, okay, to help augment the BNP. BNP here, technically the BNP, its only purpose, to say the least, is it's only a diagnostic tool, right? So because no other organ in the body produces ANP and BNP, so therefore, what's its main purpose? A diagnostic tool for heart failure. Yeah, because no other condition will have an increased level in ANP or BNP. So its only purpose really is a diagnostic tool. Diagnostic for treatment and also to evaluate diagnostic whether or not the treatment is effective. Okay, so if BNP levels rise, that means is the treatment effective? We need more treatment. If the patient's BNP levels are dropping, then the treatment is working. What's causing the BNP to be released again? Okay, the stretching or distension, the over distension of the heart chambers. Okay, so the ventricles will release BNP, and of course the atria will release ANP. Between the two, I hardly see ANP ordered. It's really just BNP. Because of course, is it necessary to get ANP? No, if your BNP is high, then the ANP is high. So doctors won't bother ordering that. So again, as the heart, the workload increases because of your epinephrine, then patient's heart will continue to fail because now it's not pumping enough oxygen for circulation. Then it's consuming what little oxygen is circulating, right? By pumping fast. There are two types, like I said. So let's look at left-sided versus left-sided heart failure. I mean, left-sided versus right-sided heart failure. It's really simple. Let's go to you can watch this video, okay, on your own. Again, you can only watch this on a desktop or laptop because the program used to create this is not on the iPad. It's not on iOS, but I think a Android can play it. I don't know what the player is, but I know it's not on iOS. So let me explain it this way. So simplest way is, let's look at the physiology of the heart. Okay, use your imagination, okay? So, okay, so this is the left side, right? Left, this is the right. That's the atrium. That's the right ventricle, left atrium, left ventricle. Let's start with the right side. So this guy fails. Remember, there's a pulmonary artery coming out here which goes to the left and right lungs, correct? And there's also big vessels here. This is the superior and the inferior vena cava. So the right side fails. It's pumping, but not effective at all. It's pumping very weak. The right side has two jobs: receive blood and get rid of it, pump it. Receive it from the upper and lower parts of the body and then pump it to the lungs, right? That's its job. That's what it's made for. So, for let's say you're 36 years old, it's been doing this for 36 years and 9 months. Okay, because no, not 9 months, 8.5 months, because the heart formed when you were 2 weeks old, right? Okay, so it's been doing that for a while. If it fails, so what's happening to the blood that's supposed to enter it from the upper parts of the body? From the head, the shoulders, the arms. Okay, so it's stuck there, right? Okay. What about the from the lower parts? So from your esophagus down to your toes, they're supposed to come back. So what's happening? Okay, so what's the problem mainly in right side heart failure? What signs and symptoms do you expect? Systemic congestion, right? Because there's congestion everywhere, there's traffic everywhere. Okay, so you can sum it up in systemic congestion. So what happens? Correct. So what happens to the neck veins? What happens to the arms, the legs? What happens to the size of the liver? There's hepatomegaly, right? So the liver will enlarge and of course it will leak. So the fluid will eventually go into the abdomen as well. Okay. And what happens to forward blood flow? No, the blood that's supposed to go to the lungs. No, no, no. Okay, not enough blood getting to the lungs. So therefore, how much blood returns to the left side of the heart? Very little as well. So how much will come out? Also, okay. But mainly, what are the manifestations? Systemic congestion. I'm just summarizing, okay? The details, of course, you have to read the paragraphs. Okay, let's go now to the left side. So the left side, just like the right side, has two jobs. If the right side is receiving blood from the systemic circulation and then pumping it to the lungs, the left side is going to receive blood from where? From the lungs, from the pulmonary circulation, and then it will pump it where? To the rest of the body. So starting from the brain, because the first two branches of the aorta are the carotid arteries, right? You've got carotid arteries and then the bronchial arteries and so on. So what are there are two sets here. The right side only has one set, systemic congestion. The left side has two sets of problems. One is there congestion here? No congestion? Where is the congestion? Yeah, there's pulmonary congestion here, which is manifested by edema. So this is flash pulmonary edema. What about number two? Decreased cardiac output, because the left side, the left ventricle has very little blood to pump out of the aorta. So the rest of the body, nobody gets enough blood flow, starting from the brain all the way to the toes. A very little blood to go around. Again, two sets. We have pulmonary congestion, which is crackles. What else? Pulmonary hypertension, and then cardiac output. What are signs of low cardiac output? That's starting from the head. Lethargy or altered level of consciousness or decreased level of consciousness. What happens to the GI tract? Okay, decrease because there's not blood getting there. So decreased peristalsis. What happens to the kidneys? Okay, anuria, oliguria. What happens to the legs and toes? Is there really swelling? I mean, imagine just left side. Is there really swelling? No. Yeah, there will be weak pulses, right? Weak pulses. And what's the color? Pale. Okay, all right. So if you go to the manifestations here, there you go. These are your manifestations. Yeah, left side. Pulmonary congestion, and then decreased cardiac output. Here you have a summary, but this chart though doesn't specify whether it's left side or right side. That's the problem. They jumbled it together. But you can say this one, the low cardiac output, this is definitely left side or right side?
Left side.
Definitely left side. The pulmonary, the congestion here didn't specify though whether it's pulmonary or systemic congestion. That's the problem. So this is a combination of both left and right side. It definitely weight gain is this left or right side? It is right side. Independent edema, left or right? Right side. Very good. Abdominal bloating. Right. Ascites. Right side. JVD. Okay, very good. What about fatigue? Left side. Very good, children. All right. So same thing, next gen type question. So you're just dragging, dropping this, or maybe a matrix. Okay. Now, why is it necessary to distinguish left or right? Well, which one do you think is the more acute, the left side or right side? Look at the chart. Do any, well, except dyspnea, but most of the congestion manifestations, are they really acute? No, except for dyspnea and crackles, right? Yeah, that's acute. But then the rest really are no, they're not really I mean, they're not urgent. Okay. Yeah, we'll treat them, but not this minute. They won't kill the patient. But look at the low cardiac output. These are acute. Okay, these are acute, need to be treated. So which one is more acute? Left or right side? The left side is more acute. But for most patients, though, they will manifest, especially if it's chronic heart failure, they manifest both left and right side. They will have a combination of both. For rationales for each manifestation, please read on the paragraphs. Okay, so for instance, why is the patient orthopnic? Why can't they lie flat?
Because it's low cardiac output, so low blood pressure.
Okay, and what else? Okay, yes, and also the lungs are wet, right? Okay, that's another. What about this one? What's the rationale for PND? Why are they awakened at night, short of breath, sleeping fine in the middle of the night? In the middle of the night, they get up, can't catch their breath. Okay, they feel like they're dying.
All the fluid is sitting on their chest.
Actually, the rationale, if you read the rationale for that, it says here somewhere that because the right here, fluid accumulating in the dependent extremities during the day may be reabsorbed at night during sleep. Okay, so they reabsorb. So therefore, suddenly what happened to the blood volume? Suddenly it increased, waking the patient up because they can't catch their breath at night. Yeah, at night. Because remember, the day they have their what? Yeah, their well, it depends on the severity. So they have basically overall metabolic demands are higher, right? There's not much the metabolic demands when you're sleeping. So now all of a sudden, the decreased cardiac output during the day wasn't enough, but suddenly at night, somehow it became enough because the patient was not doing squat. They were just laying here sleeping. So therefore, Yes, decreased cardiac output, but it's enough for a sleeping patient. So now blood volume returns to the vascular compartment. So I'll leave you with the rationales. Let's go on, and then same thing for the right side heart failure. Okay, so you explain why the liver is big, okay, why there's fluid in the peritoneum, okay, why there's dependent edema, etc. Why the urine output is low. Let's go now to treatment. Before okay, let's stop here. Pulmonary edema is the number one reason why the patient would go to the hospital. So number one complaint is they can't breathe. They're suffocating. This is how bad the pulmonary congestion is in acute heart failure, in left side heart failure. So the lungs basically are wet. Now, can you ventilate a wet lung? No. I mean, how can gas exchange occur, right? Lungs are wet. Yeah. Just like when you fart, for instance, you're in the pool. Okay. You're in the pool, right? So let's say Daniela is in the pool, right? She farts. Yeah, it'll come out. But let's say, can Angela fart into the pool? Let's say she's on the ledge having her drinks, okay, and then she farts. Can the fart enter the pool? No. So therefore, gas exchange cannot happen if your lungs are wet. You see the analogy though? Okay, so we call that flash pulmonary edema. This thing happens like this. They were fine at 1 o'clock. Now it's 5 after 2. Now they're symptomatic now. That's how fast this thing can occur. Okay, can develop. So they go, no, they call 911. So diagnostic findings. So of course, the heart failure manifestations, you saw them. Are they exclusively in heart failure? No, it could be somebody having a heart attack also, right? Or having a COPD or asthma attack. So we can't tell whether is this AFib. Okay, the AFib manifestations the same. So therefore, we draw everything. So when they come into the ER, let's draw all the blood work. So let's check if they're having pulmonary embolism also. Have the same manifestation. So we'll check them for PE, for heart failure, for a heart attack, for uh, everything. Okay, so we'll draw all the blood, and then other testing that will be done is echo. Okay, so we do a transthoracic, which is a 2D echo to measure ejection fraction. This can be done multiple times, but basically at some point, once this patient, especially if this patient is known to have heart failure, so the cardiologist must have done an echo as a baseline, when they were asymptomatic. So they've done a baseline. So this is your normal ejection fraction. What is ejection fraction? And why is it in percentage? Okay, look, expected ejection fraction is 55 to 65% of the ventricular volume. So what is this measuring? Okay, so the blood entering the ventricles, how much of it comes out? So therefore, if it's only 55 to 65, which is normal, do the ventricles really empty? No, they do not empty. Yeah, only half to three, about almost 3/4, right? Comes out. Okay, so that's normal. In patients with pretty bad heart failure, let's go now to the classification. Usually when they're under 55, let's say 40 or 30, or let's say under 30, then that's pretty bad. Okay. All right. So we have to know table 25-1. One of our graduates long ago came back, and you're not supposed to talk about the NCLEX, by the way, but you know, I won't tell. Okay. It's not like we'll call the cops. Hey, this student here talked about their NCLEX exam. It's not really a crime, but you did sign a document saying, I will not talk about the NCLEX. Okay. But I don't know what teeth that thing has. I mean, it's not like perjury or no, it's not wasn't a well, it's the non-disclosure, right? But there's really no penalty. So I don't know how they're gonna enforce it. Anyway, so table that 25-1. Um the student said the question went there was a uh 37 week of gestation patient that came in. She had class 2 heart failure. Okay. So on its face, it sounds like a OB question, right? But no, it was a med surg question because she just happened to be pregnant, but she has class 2 heart failure. And then the question was, what will the nurse prepare to do during this visit? Okay, because it was a OB clinic. What will the nurse prepare to do during this visit? A, follow up on the progress of the Lamaze classes because 37 weeks is due, right? They're due. Okay. So are they doing well on the Lamaze? Number 2, um, schedule a C-section. Number 3, schedule a C-section stat. Or 4, check if they're taking their prenatal vitamins. 1, 2, 3, or 4? 3. How about you? 3. Okay, the answer is actually 2. Okay, so here's the rationale. So let's go to heart failure classification. So the universal metric for heart failure classification, most hospitals in the world use the NYHA. Okay, so NYHA uses 1, 2, 3, and 4. For me, I only need to remember 2 and 3 because look at 1. In class 1, how does this patient look? No symptoms. Okay. Ordinary activity does not cause any symptoms. Ordinary. What are ordinary activities? Yeah, like right now. We're this is all ordinary, right? None of us are doing anything other than ordinary. Walking to the bathroom, yeah. We took a shower today, we ate, okay? We had a bowel movement. Okay. All right, that's ordinary. Look at class 4. Unable to carry out any physical activity without discomfort. So where are these people with class 4? Are they here? Where do you see them? Yeah, or ICU, right? Or maybe hospice, right? Look at that. Symptoms at rest. They're just sitting down or laying in bed. They are symptomatic. They have fatigue. They have shortness of breath. Any physical activity causes increased discomfort. So these people are dying. Yeah. Or, they need to, say goodbyes. Okay. That's basically it. Okay. Yeah, let's face it. I mean, because can you get a heart at the supermarket? What are you gonna do? Huh? No. Hey, these people are pre-departure. Okay, they're about to die. Now that leaves us with class 2 and 3. What is class 2? Slight limitation of physical activity, comfortable at rest, but ordinary physical activity causes fatigue. Class 3, limitation of physical activity, marked limitation, comfortable at rest, but less than ordinary physical activity causes symptoms. What did our pregnant woman have? Class 2. So that woman is comfortable at rest, but ordinary physical activity can cause symptoms. Okay. Is 37 weeks. That patient is going to go into labor soon, right? Are they in labor during the visit? No. No. So therefore, what's your choice now? Number 2 or number 3? Number 2. They don't have to have C-section right now because she's not in labor, right? There's no indication in the scenario that indicates she's, having contractions. No. But is she allowed to go into labor? Is she allowed to go into labor? It'll kill her. Okay? Labor will kill her because is labor ordinary physical activity? No, look at this. Ordinary physical activity causes symptoms. So, how do you describe labor? I've never had, I've never gone into labor, but I don't know what that looks like. Okay, I've never seen it because my wife, had 4 C-sections, so I don't know what a woman in labor looks like. Yeah, I mean, I've seen it, when I went to clinical, but not personally. Okay. All right. So, do we need to know heart failure classification? Okay. Yes. So we only need to remember which ones? 2 and 3. Okay. So 1 is easy, no symptoms, they're fine, they like you and me. Class 4 on their deathbed. Okay. So 2 and 3 are the only ones you really need to distinguish. All right, let's go to management now. You can disregard this, and this is another classification, but again, which one is more reliable or which one is NYHA? Here's management. So what do we do? So the management here will be divided into pharmacologic and then non-pharmacologic. With non-pharmacologic, there's invasive interventions as well, which includes heart transplant. Okay. So these are our goals. Optimal pharmacologic management, reduce symptoms, stabilize the condition, meaning reduce hospitalization, and then delay the progression, then promote uh, better lifestyles. Okay. So first, drugs. So what drugs are used? Let's go straight to the table. Table 25-3. So here we go. Diuretics. So there are 2 things we need to address here. So drug therapy will either, no, 3. Will do one of 3 things. 1, do you know what is preload? What is preload? Is it? Volume. Okay, so when we say preload, that's the blood volume. Okay, so what do we want to do to the preload or the blood volume? Decrease. We want to decrease it. Okay, so we want to decrease preload. What is afterload? The blood vessels. Very good. So what do we want to do to the blood vessels? Dilate or constrict them? Dilate. Very good. So decrease preload, decrease afterload. What do we want to do to the contractility of the heart? Increase it or decrease it? It's weak. It's in failure. We want to increase it. Okay. So those are our 3. So we have 3 sets of medications. One set will decrease preload. That could be 1 or more medications. Decrease afterload. Again, that could be 1 or more. And then finally, we will increase the contractility. Now, not all patients will receive the increased contractility, okay? But definitely all heart failure patients will receive drugs to decrease preload and afterload. Okay, so let's start with diuretics. So since diuretics remove fluid and electrolytes, what will this do? Preload, afterload, or contractility? What is this doing? Preload. Okay, this will decrease preload. What about angiotensin system blockers? We have ACE inhibitors and ARBs. What do these do? Afterload, okay, because they are vasodilators. Okay. All right. This one is this is fairly new. It's a combination now. So this one has both an ACEI plus an ARB. Okay. It's a combination drug. But because now you have 2, so look at the side effects. Okay, you know side effects for diuretics. Look at the side effects of ACE inhibitors and ARBs. hyperkalemia. So now if we combine both drugs, what could possibly go wrong? This one causes increase. What happened? So this one causes increased potassium. This one increased potassium as well. So you give both in this drug. So this pill has two drugs in it. A severe hyperkalemia. Okay, but remember, sorry, heart failure. Can this damage the kidneys?
Yeah.
So the kidneys here, maybe the patient has chronic kidney disease, right? Meaning, can they excrete potassium normally? Plus, you're taking drugs that increase potassium.
It could be more.
All right. Okay, so you come to an exam question. On the NCLEX, how much of your NCLEX questions will be pharmacology? 20%. Okay. So 20% of your NCLEX questions will be on drugs. Now, are these common drugs? Yes, half the patients you'll see on the med-surg floor will be heart failure patients, diabetes. Okay, sometimes they have all of them. Okay, they have kidney problems, diabetes, and heart failure. Yeah, jackpot, right? I have everything. Okay? So they'll have that will worsen the hyperkalemia. Okay. So what were those interventions again we discussed last week to treat hyperkalemia? Because now you'll be giving a lot of those. Okay, when these patients come in. All right. Beta blockers. So which one is this? Preload, afterload. Okay, afterload. Okay, because it causes vasodilation, right? So this will block what? It's a beta adrenergic. So what is this blocking? Blocks epinephrine, right? Blocks epinephrine, norepinephrine. And therefore, since it's blocking epinephrine, what will this do to the heart rate? Decrease heart rate. What will happen to the blood vessels? Dilate. Very good. What about its cousin, the calcium channel blocker? Same thing. Okay. However, between the two, between beta and calcium channel blockers, the difference is this one has a higher effect on blood pressure. So if you're to choose, let's say sometimes we have problems. Let's say the patient has a fib, right? And they go into a rapid ventricular response. The heart rate's 160, 180. Now, what happens to blood pressure if the heart rate's beating that fast?
It's the patient's happy.
What happens to blood pressure? Well, probably increase during the first 5 to 10 minutes, but let's say 2 hours later. Is it still high? No, because you're shortening the ventricular filling time. The heart rate is now this fast. So therefore, yeah, not enough blood entering the ventricles. So therefore, what will happen to blood pressure? So what happens if you're trying to drop the heart rate using a beta blocker, but then your blood pressure is like 92/60? You have a problem there, right? So now the doctors may decide, okay, which one has a lesser harm on blood pressure. Usually they'll choose, okay, give calcium channel blocker instead. Okay, so between diltiazem and metoprolol, we'll go with diltiazem. Okay,
Go with which one?
the calcium channel blocker.
Oh,
This drug is not really very popular, so we'll skip that. We have hydralazine, another vasodilator. Okay, hydralazine comes in PO and IV, but this one very effective for acute rise in blood pressure. So the patient has high blood pressure. It's not time for the other drugs. You can give hydralazine. Okay, 5 to 20 milligrams. And then finally, digoxin. Honestly, I mean, I don't work in a I work in telemetry, but even if I float to a med-surg floor, I don't see that many patients taking digoxin anymore.
really?
Okay, it's still, I don't know why it's still in the textbook because this thing has lost its popularity. In maybe before 2010, almost every heart failure patient is on digoxin, but because of the yeah, when we go to dysrhythmias, this thing has been responsible for heart blocks. Okay, so Brady dysrhythmias, and not to mention toxicity, because look at the combination. These patients will be on these drugs, right? So they're taking diuretics, and then they're taking digoxin. Diuretics cause hypokalemia, correct? And then hypokalemia leads to digoxin toxicity. So it's not a good combination. Plus, again, the what discourages the providers is this thing causes Brady dysrhythmias. It's been associated with so many arrhythmias. So it's not very popular because its function actually, which is to improve cardiac contractility by decreasing the heart rate, can be accomplished by beta blockers. Although the contractility is not really improved by beta blockers, but our goal basically is to improve cardiac output, right? So digoxin, basically, I would say it's not worth it anymore.
Sure, the best.
Well, all the other drugs we're still using, except this one. Maybe a few, maybe, if your doctor is 70 years old, 80 years old, they're still prescribing digoxin. But young providers, they're not giving this anymore. Okay? Because so many studies are coming out saying it's not really, yeah, it's not, I mean, the benefits of digoxin is losing its, its touch. It's not worth it really. Further discussion for each one. I know I just stayed with the table. Please look at the rationales on the paragraphs. Okay. And remember, for diuretics, there are many types. We have potassium sparing and potassium wasting. Here's a teaching for when you're giving diuretic therapy. Diuretics have been, although gout is in the last module, but here's the mention about avoiding diuretics for patients with gout, because diuretics cause high uric acid. Not to mention dehydration, etc. Here's the cardiorenal syndrome. Okay, as a consequence of chronic diuretic therapy.
So in that case, you give the combination with gout medication with the diuretics.
Again, that's not for us to decide. Doctors will have to weigh, okay? Because I'm not saying gout is not important, but gout is, it's pretty serious. Patient has severe pain, okay? But they'll have to discuss the benefits of continuing diuretics, because which one's priority?
The heart.
Yeah, so sometimes, we can't avoid it. However, there are diuretics that are less likely to cause gout than others. But again, that's not our decision. Between ACE inhibitors and ARB, which one causes that nagging cough? The ACE inhibitor. So that's an option, by the way. So yes, we know that ACE inhibitors cause the dry persistent cough. Doesn't mean we're gonna tell the patient, oh, suck it up, because that's a expected side effect. No, because what will the patient do if it's causing a cough? They'll stop taking it. Okay? I can't sleep. This thing's causing me nonstop cough. I can't sleep, and I'm tired in the morning. So they'll stop taking it. So what's your option? Okay, ARB does exactly the same thing without the cough. But keep in mind, both will cause hyperkalemia. Especially now, again, what was that drug that will, there's a combination, right? What's the name? Yes, sacubitril and Entresto. Yeah, that's the brand name. Probably seen it on TV. Okay, for the few people that we still see taking digoxin, let's discuss digoxin toxicity. So if it's basically the drug enters the cardiac cells via the sodium potassium pump. Okay, that's how they enter the cardiac cells. So are they dependent on potassium? Yes. So potassium levels must be normal for digoxin to be effective, for them to enter the cell. If your potassium levels are low, because the patient's taking a diuretic, for instance, so what will happen to the digoxin? And they enter the cardiac cells. They will stay where? In the bloodstream, causing toxicity. Now, toxicity symptoms are the following: anorexia, nausea, visual disturbances. Visual disturbances, we mean the test may say blurred vision or double vision. Okay, that's the visual disturbances. Okay, or other textbooks will say there's a yellow ring around lights. Okay, so yellow halos around lights. Okay, confusion and bradycardia. So these are the toxicity manifestations. What about if the patient's potassium is too high? It will also cause problems. It will also cause the digoxin to be ineffective. Low potassium causes what? Toxicity. Too much potassium causes, like it causes digoxin to be ineffective. Okay, I'll skip the IV infusions. I'll reserve this for cardiogenic shock, which is the first topic next semester, because it'll be redundant. We discuss it now, discuss it again in shock, but this is really more for cardiogenic shock, because the patients who receive these are in cardiogenic shock. Okay, so we'll skip that. So these are the drugs used to treat cardiogenic shock: dopamine, dobutamine, milrinone. Okay. For vasodilators, let's say nitroglycerin, we'll discuss that also next semester under acute coronary syndromes. Okay, nutritional therapy, and then we'll take a break. Low sodium diet. Now, there are 3 levels of low sodium diet. So the strictest is 2 grams sodium per day. You know how much 2 grams is? No, when you buy crack, it's just a little bit, little packet. Yeah, you buy crack. That's 2 grams. But that's for the entire day. Okay. So that's 2 grams. Okay, it's very little. Okay. And that's for the entire day. And how many meals do you eat? Say you eat 3 times. So you have to divide that little crack packet of salt. Not crack. Crack packet. Okay, but you have to divide it into 3 meals. So it's pretty bad, right? I mean, it's yeah, the food will taste terrible. The others are not so bad, because other levels, which is better, is, let's say, uh, no added salt. No added salt, that's good, because that means you can still eat, let's say, tomatoes, which are naturally salty, right? As long as you don't add any more salt. So that's no added salt. And then there's also um, a different level. But anyway, the most serious is the 2 gram sodium. Now, so therefore, patients resort to salt substitutes. Okay? So let's say Mrs. Dash, for instance. Now, salt substitutes, instead of having sodium, they contain potassium though. Okay. So the cheap salt substitutes contain potassium, which tastes like salt. So warn the patient against that, because let's say, what drugs are they taking that will be bad for salt substitutes?
The job.
Well, not really, because
No, that's potassium,
ACE inhibitors and the ARBs, okay? 'Cause those cause hyperkalemia. Plus, you're using salt substitutes which may contain potassium. Okay, there are non-potassium salt substitutes, but they may have to pay more. Okay, so instead of just $1, they'll pay like $7 for a salt substitute. Okay, there are more expensive. I mean, you may be okay with that, but who are these people who have heart failure? Retirees. Okay, they're on Medicare. So Social Security, they're on a fixed income. Do they have a budget for $7 on a salt substitute? Probably not. They can use that $7 for chicken, yeah, yeah, or beer, yeah. What beer is $7? There's even the local beer, domestic, is not $7 anymore. What are you talking about? Oh, okay. All right, let's take a break and then we'll continue. Come back at 2:55.
Yeah.